Hello and welcome to today's webinar. My name is Marilyn de Guzman, editor of Canadian Chiropractor Magazine, and I will be your moderator. Today's webinar is brought to you by Canadian Chiropractor Magazine and sponsored by Innotech Rehabilitation Products. This presentation will run for 45 minutes with time for Q&A at the end. You may ask the speaker a question anytime during the presentation by entering your question in the question and answer box in the control panel on the right-hand side of your screen. We are recording today's session, and everyone who registered will get an email with a link to the on-demand version within the next few days. If you're having technical problems, send a question from the question window or call toll-free at 855-352-9002. Now I'm sure you're all eager to hear from our presenter as he discusses why there is no such thing as non-specific back pain. We are honored to have a well-respected author and international speaker with us today. He is a professor of spine biomechanics and the director of the Spine Biomechanics Lab at the University of Waterloo. He provides regular consultations on difficult back cases. His advice is often sought by governments, corporations, legal experts, and elite athletes and teams from around the world. Please welcome Stuart McGill.
Well, good afternoon to you all. I thought I'd start with this quote from the great Czechoslovakian neurologist, Dr. Karel Levitt. The first task for the physician is to show the patient the cause of their pain. Nonspecific back pain, lumbosacral strain, idiopathic back pain. I've never heard of a patient being told they have nonspecific leg pain or nonspecific head pain. Why do we do this with back pain? There are those people who just simply haven't been given a proper assessment. Degenerative disc disease. It's a common diagnosis, yet it doesn't guide treatment, and I will argue that it may be detrimental. It causes a lot of anguish. For example, it's akin to telling your mother-in-law, who has a few wrinkles on her face, that she has degenerative face disease. In contrast, a diagnosis of something like pain triggered by flexion intolerance, it's helpful. It directs the treatment and it tells the patient how to avoid the pain-causing mechanism. This particular patient was told they had degenerative disc disease, which is nonspecific. I'm assuming at this level, which looks as though it's been damaged. It doesn't have degenerative disc disease. Very clearly, there's evidence of compressive overload. We see edema around the Schmarl's node, bulging both anteriorly and posteriorly as the disc is flattened, and we see a focal disc bulge posteriorly. And there's markers at other levels as well that clearly show mechanisms that I will show are linked to pain. However, this patient doesn't have nonspecific degenerative disc disease. They actually have a modulated load intolerance. Their pain is triggered by both movement into flexion and into extension, yet preserving a neutral spine reduces their pain. In fact, it completely eliminates their pain. It shows them what to avoid and very precisely what to do. So I'm going to tell my little story today. There is no such thing as nonspecific back pain, and the basic theme is assess to obtain a precise identification of the pain trigger, then avoid the pain trigger to desensitize the patient, and then build the foundation for pain-free movement. The approach can be powerful in producing superior results, but it needs a very robust scientific foundation, and the foundation has three pillars: an in vitro lab, an in vivo lab, and the patient clinic. In the in vitro lab, we take spines and we create the injuries. We compress, we shear, we do different types of diagnostic imaging, whether it's CT or plain film or contrast radiography, for example. In the in vivo lab, we take real people and we measure spine motion, we measure how their motor control system is activating their muscles, and we ask very specific questions. For example, in this particular study here, we were wondering why some patients report increases in pain with work on an elliptical trainer, yet others have pain resolution. And the most dominant variable that we found was hip mobility. Those with very mobile hips can enjoy the extra gluteal stimulus given by an elliptical trainer. In contrast, those with stiff hips, the restricted motion then goes into their back, and it's those patients that are exacerbated by that particular intervention. Well, then we create a virtual spine most of the time. We will start by plain images, either MR or CT, and then we serially stack those to create a 3D virtual spine of that person. So as they move in 3D, we mimic and drive their virtual spine where we're able to measure disc deformation and stress, ligamentous stress, etc. As the patient moves, we capture their motor control scheme through muscle electromyography, which then activates their virtual muscles, and then we can create stress maps looking for tissues that carry the highest stress and are closest to their tolerance. We can actually measure things like spine stability, for example. And then the third pillar is our seeing patients in the clinic. And we don't see the average bad back. The average clinician does very well with that. Or I shouldn't say average clinician, but the common clinician. Instead, we get the worst of the worst, and we also get the best of the best, some of the best high-performance athletes in the world. Well, I want to start with this supposition now that exercise reduces pain. Let's follow this pathway where we have created evidence at each level. For example, repeated spine flexion with a certain amount of compressive load will create a progressive disc herniation. But the posterior migration of the nucleus then travels into the disc bulge region, but this is reduced by reducing the hydraulic pressure by avoiding the motion and load that caused it in the first place. The bulge will then shrink, and the open fissure that the nucleus traveled through will gristle over time, hence reducing pain. So let's follow this pathway. And to give it a clinical context, we're going to follow three different levels now. First, we'll assess the patient. We will then remove the cause using elements of spine hygiene, and only then will we prescribe specific exercise to build a pain-free resilience to movement. So, in this case, what really causes injury and ultimately pain? Well, I've given two examples here. Let's look at the right first of all, of a disc where the nucleus was injected with ink, and we see a frank posterior lateral herniation. And we see the same in this experiment as well. The chromium blue injected into the nucleus traveled through a fissure, and we see it into the delaminated collagen here. Well, it really is only one way to create this particular type of a disc damage pathway. This is one of our machines that creates disc herniations, and the spine is stacked between the two rams, and it's flexed over and over and over again under different types of compressive load and twisting load, or whatever the experiment dictates. So if we follow this story of the dynamic discogram here, there is the virgin nucleus. We've loaded the center with a radio contrast, and we begin flexion cycles under load. We see the progression of the nucleus tracking through the delaminated collagen with repeated cycles of load until ultimately we create a disc bulge, and eventually still will be extrusion of the nucleus. All of this occurs unbeknownst to the patient, by the way, until the final bulging and extrusion. Well, this is a model built on the results from our laboratory, and we see here the delaminated collagen, which is closed at the moment. But that closure is a function of load and posture. So here we see a spine with a neutral lordosis, or what we would call elastic equilibrium, and if we were to squeeze it, there is nothing that will really happen at the site of existing delamination. However, when the person flexes and then applies compressive load, the hydraulics create pressure posteriorly, the nucleus travels through the delaminations, and you see how it bulges right here. So if I was to show a close-up, when the line of drive of force is right down through the center, the thrust line as it's called, with no spine deviation, the delaminated collagen remains closed, but it opens up with flexion, and the hydraulics drive the nucleus posteriorly. Well, a bit more on this mechanism. This comes from the micro-dissection and surgery work of Claudio Tampier, who's one of my graduate students, also happens to be a very skilled orthopedic surgeon. The nucleus was loaded up with a chromium blue, and he skillfully pulled off layer by layer of the concentric rings of the annulus. So we see here just the hint of something coming through. He cuts another layer off, and we see a bit more exposure on the delamination. And here again we see this, what we ended up calling nuclear worms, and you can start to see why. These are worming their way through the delaminated collagen. All right, well, how to detect such a situation? Here we're going to take a patient, have them sit on a stool, and they pull up on the stool with their hands, essentially creating a compressive load down through a stacked spine. And then you ask the patient, did that replicate your symptoms, either a low back pain or might have been a radiating symptom down their leg, or if it might have gone to their left big toe, for example. Then we ask them to slouch, flexing the spine, causing hydraulic pressure on the suspected mechanism that I just described. If they say yes, that increases their pain, and that pain might ramp up over a minute. That is indicating dynamic travel due to that nuclear pressure. Now let's add some neural tension. We might ask them to flex their cervical spine, adding cervical tension from above, and the patient may say that makes the radiating symptoms or the back pain worse, and extending the neck, taking traction load off the spinal cord, they might say, well, that makes it better. But you will find that 1 out of 20 patients with this mechanism of pain reports precisely the opposite. This reduces pain, and this increases pain. Now you've just identified those with a neural underhook. The bulge is underhooking the nerve root. So this slackening of the cord from above allows the cord and root to drift down into the offending trap, whereas this pulls off the trap. So this throws a lot of clinicians, yet understanding the precision of the mechanism then allows you to understand the diagnosis. Well, let's take a different mechanism now. This I've taken off the internet from someone who believes in spine power and twisting. Allowing the spine to twist as the rib cage twists away from the pelvis in these Landwein exercises. Yet when you mimic this load and this motion, the delamination pattern changes. Between the concentric layers, they start to split and delaminate, and we see the nucleus traveling up between the layers. The prophylactic or preventative movement is to still allow twisting torque, but here the rib cage is locked onto the pelvis, and the rotation takes place about the ball and socket joints, the hips, the shoulders, and spinning around the balls of the feet. Well, there's more to the herniation process. Recent studies have now shown that the extruded nucleus harvested during surgery often contains bits of cartilage, and you'll see that this is now evidence of compressive overload. What we've done here is using state-of-the-art micro-CT. We'll take a virgin spine, which we've documented on the left, and then we will compress it with the loads associated with a double body weight deadlift. And you will see after that compressive load, all of the trabecular bone underneath the end plate has been fractured. So the scaffolding holding on the cartilage has now been compromised. So when you load it in compression and start bending cycles, little bits of cartilage pull off because it's no longer got a scaffold to hold onto, and it will be carried out via the hydraulic pressure that I'm describing through the pathway into the bulged area. Well, how to detect such M-plate damage? We found that having the patient go up on their toes and landing down rather abruptly on their toes creates a compressive load of 1.5 times body weight, and is quite sensitive at picking up that particular pain trigger. Well, more precision. Heredity matters, but it has a large component of an anatomical foundation. I'm showing two different discs here in cross-section. This is an ovoid disc, and this is one that's been called a limacon shape, typical of heavier boned people. Interestingly, the herniation patterns are quite different. In the ovoid disc, the herniation delamination pattern tends to be more diffuse, an angle of greater than 45 degrees. You'll find that these do not respond very well to directional therapies. I'm thinking of McKenzie therapies, for example. In contrast, the limacon-shaped disc has a stress riser because of the anatomy, and it focuses the travel through to the apex of the limacon, creating a posterior lateral bulge. And by the way, these are the ones that are best responsive to directional therapies, as I'm showing on a contrast CT on the right. So there are genetic links, but perhaps not in the way that is commonly discussed. You do inherit these anatomical features from your parents. So to summarize where we are thus far, creating a disc herniation, it's a fairly precise process. It's a repeated flexion, a cumulative trauma with compression, but the compression must be rather low. It's caused by poor movement at lower loads, because higher compressive loads actually start off M-plate damage prior to the herniation. Well, let's keep adding to the precision here. What we're going to do in this experiment is change the axis of bending motion to a 30-degree angle that we're showing here. Interestingly enough, about 100% of the time, the nuclear pressure is now directed to the opposite corner. So I hope when you go back to the clinic tomorrow and a patient comes in with a posterior lateral disc bulge, you ask what side is it, and then you investigate their movement patterns to find out why they have suffered this very directional bias to the disc bulge. All right, well, there's a little bit on assessment. Let's move on to removing the cause now in this particular example. I realize that this is a test for spondylolisthesis. It's setting up a shear load, but interestingly enough, we have about 5 to 10 kilos of traction on each leg. And if this resolves the symptoms, we found this is about the best disc vacuuming pressure to resolve the dynamic disc bulge that I just described. Well, adding a bit more precision, we then add a shake side to side of a couple of centimeters of the feet to put a gentle roll in the pelvis. That motion adds to the vacuuming pressure on the disc. But interestingly enough now, if the patient has micro movements in their spine that are part of their pain genesis, this will make them worse, not better. So then we ask them to push an eyebrow, for example, down into the table, adding anterior chain stiffness, and they might say, ah, you just took my pain away. So again, we're honing in on the precision of the mechanism and the diagnosis and what helps and what makes the pain worse. Well, let's move on now to removing the cause, and we'll look at the techniques of spine hygiene, which I've documented in my new book, Back Mechanic. I ask every patient when they come in to take their shoes off because it reveals to me their movement habits and quite often why they have unresolving pain. I show them then how to avoid the pain trigger by adopting a lunge, rolling the knee over the foot, keeping the spine in a neutral posture, and avoiding the pain trigger. Brushing their teeth. They tell me, well, we're fearful of brushing our teeth because no one has shown them very precisely their pain trigger. Yet when we show them how to close the chain, lock the spine in a neutral position, and flex around the hips, all of a sudden they are just resilient. No chance of a pain trigger. You've eliminated the cause. We then look at other elements of their life where we can make them more resilient and build painless training capacity. For example, I've talked about the hydraulics and what causes the disc bulge. If we put a lumbar support when they're sitting, we build training resilience later on in the day. We're putting training money in the bank, so to speak. Another product that we've just developed is the same kind of pneumatic support for when people are laying on their backs. If they place their hands palms down under their low back and say, that takes my pain away, you've just identified yet another type of pain trigger. And if we can support that curve while they're sleeping with this adjustable pneumatic sleeper, they will then wake up in the morning with more resilience for the rest of the day. And I'll just finish off this spine hygiene section with this example. Many clinicians give patients the instruction, if you wake up with morning stiffness, pull your knees to your chest. And yet when we examine this mechanism, we find they are playing with the stretch reflex, which gives the patient about 20 minutes of analgesia, not realizing that the disc bulge underneath, which is the offending pain trigger mechanism, actually grows so that they will have to repeat the procedure again tomorrow and the next day and the next day. Stop this procedure and they will be stiff for a few days, but their pain quite often starts to resolve into the desired direction. And I'll just finish up this with a little anecdote to show precisely the opposite. Here was a patient who came in, and of course they had the diagnosis of very mild degenerative disc disease, which I'm assuming due to this little highlighted area that we see in the front of the disc. And yet when we played with the contrast, the mechanism was revealed in great detail. We see an anterior fissure and a dynamic disc bulge, and that is then going into the torn disc that we see anteriorly here. They were triggered by extension. When they got out of a chair, when they started to ascend from a deep squat, they cranked their back, if that's a proper word, into complete extension. And they were absolutely mystified why this caused them more pain. Even more ironic was that their therapist got them to do repeated spine extensions as part of their therapy. And of course, when we measure this, this increases the, well, not only the pain clinically, but the tracking of the nucleus through this anterior pathway. Well, I'm just going to discuss some recent work now, which is pioneering. It's the first ever in the world. For all of those of you who are primary care clinicians, you've been asked the question from your patients. We're now abstinent because the last time with a little, I'll call this very politely some midnight movement, they are now fearful of undergoing that amount of pain. There is no guidelines available to clinicians on what to do. So we, for the first time ever, took 15 couples, measured their spine loads, hip loads, etc., in different positions to try and create an atlas to guide you as clinicians with the patients. But just incidentally, this was the most successful media release from the university. I believe it touched over 3 billion readers. It was front page in Costa Rica, Norway, Spain, Italy, Portugal, the UK. We even made the front page of The Economist, broke back mounting sex and backache. But we see again, we made China, the UK, etc. But the purpose was to create an atlas So your job as clinicians is to determine the intolerance or the pain triggers of your patients. It might be flexion, it might be extension, it might be shear, it might be compression, could be bending. In any case, find the appropriate atlas page, and then you will be able to direct your patients to different physicians that will help them avoid their pain triggers. Well, let's move on to the next exercise in logic, and I just want to go through one other pain injury scenario. So let's start with this progression. Injury causes joint instability. That's beyond refute. And now I'm just going to follow each one of these, which again in isolation have all been tested with mechanistic studies. We will then address the joint instability by creating joint stiffness. That will arrest or certainly decrease the joint micromovements, which reduce the nociceptive stimuli of the joint, ultimately reducing pain. So let's follow this pathway. So once again, we'll assess, remove the cause, and design an appropriate exercise. Well, this test turned out to be the most effective predictor of those who would do well with spine stabilization exercise. It's the prone instability test. We set up the patient laying prone on the table with their hips just on top of the edge of the table. Their toes are actually supported on the floor. This is a very poor setup because the spine is already broken in full flexion, so you'll get a false read on the actual pain triggers. But then we probe. My thumbs are on the PSISs, so I'm going to start on the sacral tubercles, L5, L4, L3, L2, and this is the probing force underneath my thumb. This is the time history on L5. You see it's about a 1 kilogram rattle that I put onto their back, L4, L3, L2, and they will usually say that, oh, there's my pain trigger, and they might go into spasm. Let's say it was at L4. It might be at several sites, but you're now honing in on what levels are triggered by this shear load on their back. Then we ask them to raise their legs up off the ground, squeeze their gluteal muscles, and then we repeat the probing. And sometimes they say the pain is less, or it might even be gone. You've just proven that adding muscular stiffness arrested the micro movements, at least to the level where the pain is gone. Or they might tell you the opposite. My pain is worse. So you've just proven that they have the inability to tolerate the compressive load that would be required with this particular strategy. Well, then we would try and take their pain away immediately. So we'll go back to the heel drop test, and you see on the left-hand side, I might coach the patient and say, could you push your fingers out, push your obliques or your abdominal wall out into my fingers here. Now repeat the heel drop. Is the pain better or worse? If they say better, good. You're starting to hone in on a prophylactic strategy. But if they say worse, then let's try a different bracing pattern. We might ask them, pull down with your pecs and lats, but leave your abdominal wall alone, and then repeat and see if the pain trigger is more sensitive or less. Either way, you get a direction on which way to begin your intervention. Our research investigations have proven the next 3 exercises to be the optimal between guaranteeing stability in a patient and arresting or at least reducing the painful micro movements, and doing it in a very spine-sparing way. So some people have misinterpreted our curl-up and they have patients doing this kind of thing, but this actually sensitizes their pain triggers. We just lightly lift the head and shoulders off the ground, a minimal amount, to not bend the spine and try and create the greatest resolution in pain sensitivity. Then for the side, various forms of the side plank, and for the back muscles, various forms of what we call the bird dog or quadruped, once again, have all been shown to be the most effective at guaranteeing stability. Well, I'm just going to move on now and add to the precision of all of this The way the person moves matters. Many of you are familiar with different movement assessments. Here is an overhead squat example, which reveals the quality of movement, but it tells you a little bit about the hardware, but it doesn't reveal their movement habits. If we then put a coin on the floor and ask them to pick up the coin, that is an unrestricted, unconstrained movement task, and suddenly they reveal their pain habits, which quite often are more important in revealing their actual pain triggers. So let's go on now and continue with some more anatomical themes. Let's look at the hips, which really govern deep squat mechanics. We're going to chase orthopedic disease around the world, athleticism, and anatomical features. For example, the highest rate of hip dysplasia is in Poland. They also happen to have the most shallow acetabulums. In contrast, the highest rate of FAI, femoral acetabular impingement, is among the Celtic nations, Ireland, Scotland, and Normandy, France. Well, what's so interesting is let's look at the anatomy now. So there is a pelvic bowl. We've aligned the pelvic ring and the sacrum. You see on the left, you can actually see the acetabulums. It's got a very low roof. This person is quite capable of a deep squat, but they won't be much of a sprinter. On contrast, this person has a pelvic bowl and ring made for sprinting, but they couldn't do the deep squats. You can't see the acetabulum, and it has a very high roof. So sprinters, by definition, must have a lot of lordosis to pre-turn the pelvis to create power through the extension range. But they would most likely be a candidate for FAI if they were to work as an MMA athlete in heavy flexion. You'll find these athletes, very rarely do they have much lordosis in their spine. In fact, they have a very flat back and a shallow acetabulum. So in many ways, the sport will find the athlete simply because of pain. So you can see again on this radiological image the high roof, which not only catches the acetabulum, but the femoral head itself. Well, as I mentioned, these are very regional through the world. I have already shown you that this anatomical hip has a very high rate of FAI. The squat strength out of the bottom of the hole is dismal. They have much better strength in the top half of their squat, hence their indigenous games. And yet when we go to Eastern Europe, for example, we see much shallower hip sockets and the ability to deep squat. So understanding the tissue stress influence really guides the efficacy of the intervention, and it guides the content of the intervention as well. So this notion that everybody should be able to deep squat, it simply isn't true. Many people cannot be corrected, and in fact they become pained if they are forced to do so. Well, do you need medical imaging to discover all of this? In fact, you don't. The hip scour test, which I'm performing here, I'm just directing and gliding the femur around the acetabulum, determining its shape and where they should squat, how deep they should squat, etc. This came from an event I did with Gray Cook down at Stanford University. I happen to know this gentleman was in the audience. He held, in his prime, 3 records in Olympic lifting. He's over 60 years of age, but when you do the hip scour test on him, you see the knee falls right up into the armpit. That's what you need to win at Olympic lifting. Well, why do higher performers get back pain? And I'm going to, because I've measured many top performance in many Olympic sports, many pro sports, why do they get into trouble? And I would have to say the most dominant cause is an underperforming core. So I'm going to measure this fellow, who's a world-class strongman competitor. They do many different events that will ultimately find your weakness, but let's just look at the super yoke, which we see here. The athlete gets underneath the yoke, which is loaded up with an ungodly amount of weight, and they have to see and carry it, see how far they can carry it. Now, the gait biomechanists will say that you use the hip abductors to allow foot plant and then leg swing on the opposite side. Well, we measured his strength to be 500 Newton meters in hip abduction strength. And yet when we measured him doing the super yoke, he actually needed 750 Newton meters. So he was doing a strength task that he didn't have the physical ability to do. But here's what we found. Yes, he fully used his hip abduction method to support the level pelvis, but he then recruited quadratus lumborum on the other side, the oblique muscles and latissimus dorsi to make the task possible. In other words, core strength allowed him to do something that he was otherwise not able to do. So we found that core strength is non-negotiable. There are pairs of muscles. For example, if you're going to run and cut quickly in the NFL, it matters not much how much you can Olympic lift or squat. What this is determined by is frontal plane strength. This isn't really trained in the weight room unless you carry heavy objects. When you carry heavy objects, this fellow in the middle here is showing what we call the suitcase carry. That's the perfect pairing of the gluteal muscles on the stance leg and then the core on the swing leg side. You cannot have an underperforming core and hope to be effective in this. Well, I'll just finish up with this final notion and address surgery, because there's no question that surgery is justifiable, but the issue is when. Many default to surgery by saying they've exhausted their conservative approaches, yet they've never received a precise diagnosis. There's no need to roll the dice if they get better with the program that I've just described. And our stats prove this to be true. In fact, 95% of the patients who are sent to us, which are some of the worst, are able to avoid surgery, even though they've been told that's their last option. But if they do fail, then at least we know surgery has a better chance for success. So in summary, there's no more non-specific back pain. Assess the mechanism. Obtain a precise diagnosis which guides, again, quite precisely, spine hygiene techniques and rehabilitation approaches, specifically what they should not do and what they should do. So avoid and eliminate the mechanisms and allow the painful tissues to desensitize. That's job number one. Then number two, build a pain-free foundation through, once again, very specific, precise, targeted exercise. Then morph into performance enhancement, and it might be to enhance their occupational athleticism or sporting athleticism. So this is all about precision in assessment, diagnosis, and intervention, which trumps general approaches every time. I've written a couple of textbooks for clinicians. My book, Low Back Disorders, describes the science, spine hygiene techniques, and the third edition really focused on a much more up-to-date assessment. Ultimate Back Fitness then takes us to the level of enhancing performance. And I've produced a few technique videos to show the precision of the technique. My most recent book for the lay public, Back Mechanic, was written, as I said, for the lay public, but clinicians are telling me they're finding this actually more consumable. Well, I'd like to thank our sponsors and the Canadian Chiropractor magazine for hosting this webinar and making it all possible, and also in particular Innotech, who I'm very pleased to have my name associated with, given the great quality of their back supports. So with that, thank you so much for listening.
Thank you very much, Stuart, and for that very interesting and really detailed presentation. Now we get on to the question and answer. We have a few questions here that was sent by some of our attendees. So one question. So you create a virtual spine for each individual, so you can simulate movement based on their spine. Is this correct?
Well, the answer to that is yes and no. Most of the time, because that's a very expensive procedure, most of the time we assume people are what we call 50th percentile, or rather normal. And we will then drive the 50th percentile virtual spine with their specific movement patterns and with their specific muscle recruitment strategies. And then we scale up the size or scale down the size accordingly. But certainly there is occasion where we need a customized spine. The person might be a 7-foot-tall basketball player or have some other anatomic oddity. We might have to alter the anatomy accordingly. So I think that gives you a rough idea of how we go about that.
Another question, where do you stand on Cook mobility before stability?
Where do I stand on Cook mobility before stability? Well, that comes from Gray Cook, and Gray has said, and well, certainly his colleagues have, I would say more forcefully than Gray, that you always start with more mobility, or you start training mobility before stability, and I absolutely disagree. I'm not disagreeing with the mobility stability. I'm disagreeing that you always start with mobility. It depends on the patient. Some patients will need to stabilize a certain region of their body to allow mobility to occur at others, and yet others you will want some mobility first. So again, it all depends on the precise pain triggers that you've assessed in that particular person.
Right. So next question, is there, the male powerlifter is from Iran, not Eastern Europe, is there any correlation between hip anatomy and Middle Easterners, given their acumen? And the same for, I guess, a question, I think, that's for Chinese in regards to jumping, flexibility, and powerlifting.
Okay, well that's a great question, and I'm glad you brought that up. I'm well aware of who the Iranian lifter was there. What I was describing was rates of orthopedic disease, but even within the countries there is quite a lot of anatomical variation. For example, I've run into a few poles with very deep hip acetabulums, for example. So all I was talking about was on average. That's the rate of disease, and hence it's not surprising that the Olympic lifters come from areas of the world that have a very shallow hip socket. And as I mentioned, the rate of femoral impingement is very geographically located as well. But it doesn't mean you won't find someone from Scotland with a shallow hip socket. That just happens to be much more rare. And again, there's all kinds of Asian hips, for example, that tend to have a shallower roof, as it's called, to the acetabulum anteriorly. But you will find exceptions. I've had quite a few patients fly in from India, for example, and they tend to have a higher roof than more Eastern Asian hips. But again, all I'm giving are averages of those countries. There are notable exceptions.
Another question here. In the clinic, how do you differ a low lumbar muscle strain, fascial strain from a disc injury without radiculopathy?
Yeah. Oh, I'm sorry, Marilyn. If I can, another thought just came back, and this is always the difficulty in answering questions. You're put on the spot. You have 30 milliseconds to come up with a wise answer. So I should go back and just say one other thing with the previous question about anatomy. Your job as a clinician is to don't ask where a person is from. It's far wiser to do the hip assessments and determine what type of hip anatomy they have, and then that will show you whether they should squat deeply, what style of squat they should use, and there are many other features. I mean, I've got 40 minutes here to give a webinar. I could talk for all day on anatomical features. So assess the individual and then advise them accordingly on what they should and shouldn't do, and when they are doing something, what style they should do it in, and you will find you will reduce their pain sensitivity. Okay, so let's get back onto the next question. How do you think, in the clinic, how do you differ from a low lumbar strain from a disc injury without radiculopathy? I'm having trouble honing in on what they're asking here. How do you differ from a low lumbar, musculoskeletal strain from a disc injury without radiculopathy? Well, then we usually begin with a history. If the patient says they've had a sudden onset of back pain, which resolves in a few days, if it's a sudden onset, that probably suggests more of a discogenic genesis. Muscular strain usually has several hours of onset and then slowly resolves after a few days and would respond to, shall we say, myofascial techniques, ART and that kind of thing. But back to the disc, we have quite a number of differential tests. The first one that I showed you in the webinar today was the seated compression test, where I'll give enough time for the disc to flow if it happens to be a dynamic disc. Then the test that I showed you with traction and the disc vacuuming technique, if that resolves their symptoms and radiating symptoms immediately, it shows it's much more of a discogenic genesis than a muscular genesis. Let's see now. The instability tests will show us if they are more joint specific than muscular. We will then work people into different types of extensor procedures, standing stork tests, etc., to see if more stability and stiffness either increases or decreases their pain. They may be discogenic at that point, but they may also be facet. We specifically load the sacroiliac joints and either eliminate them as possible candidates or still leave them on the list, but at least we can eliminate some of the muscular suspicions if we don't challenge the muscles in any way. For example, in the extensor tests, if that increases their pain, the muscles are very silent during that time. So some of the tests are inclusionary and some are exclusionary, but I've got a full list, comprehensive list in the low back disorders textbooks. And the last point I should make, I don't trivialize the assessment. I set aside 3 hours to assess a back pained patient to really hone in on this precise diagnosis. So it can't be done in 1 or 2 tests.
Okay, so this is an interesting question, which we were talking about earlier, I believe. How do you think that your explanation fits with the current pain science, i.e. the biopsychosocial model? It seems that your way of thinking is very biomechanical.
Okay, my thinking is very biomechanical. Well, it may appear that way, but if you could work with this, I'd think you'd know that for 30 years we've been spending great attention on central sensitization of pain. In our whole program to reduce pain sensitivity by avoiding the pain triggers is all about being consistent with the pain science of central sensitization and the gate theory of pain, and etc. our work with fibromyalgic patients, for example, where we found there are some people who believe just give them more progressive exercise and somehow you will beat down this pain sensitivity, and we find those patients are actually highly sensitized by this. We found that generally a better approach is to get pain-free movement going, whatever that happens to be, and allow them to desensitize their pain. But to take a contrasting view on this, some of the people who call themselves pain scientists, not all by the way, but some of them, seem to me to be ignoring completely the biomechanics and are telling the patients to just carry on and touch their toes and do these kinds of things when we can prove that that is their primary pain trigger. We get some of those patients who failed those programs, and they are the most traumatized, movement-phobic patients that I've ever seen. And yet, when we show them their pain triggers, they for the first time, realize that they are in control, and they're actually very liberated to know that they can move, eliminating the potential of a pain trigger, and they allow the pain to slowly wind down. So I think for many years we've incorporated this notion of pain science, and I would prefer to call it neuroscience because it's much more involved than just the pain. So I hope that clears up that bit of a misconception. The way to go on this is to give full credit to the mechanisms and biomechanical pathways and use the very best elements of psychology. One of the things we do is assess the personality and find out their learning style. Do they respond to visual cues or external cues or internal cues? Are they a type A personality that you have to discourage? The patient who says, you know, I went to the gym, and if I don't go to the gym, I'm going to go crazy. And I say, well, guess what? We know why you don't get better. Versus the type B personality, who we have to actually encourage to exercise. So some we hold back and some we encourage. So I think our approach is much more comprehensive than people probably realize at the outset. But if they read our textbooks, I think they would have a better understanding of what we do.
So there's one here asking you to clarify a little bit about that eyebrow push. How would that help guide treatment? Anterior core training?
Yeah, so the eyebrow push, well, that was just a very specific example. We have many, many techniques to add either stability or mobility, whatever the case may be, to try and find the mechanism to resolve the person's pain. In the example that I gave today, they were laying prone on a table, and I was adding a little bit of traction, a little bit of extension with a little bit of motion. Well, as soon as you add traction, that's a destabilizing maneuver for the patient. It also happens to be the best way to vacuum in a posterior dynamic disc bulge. But if the patient is unstable, they will say, no, this doesn't make me feel better. It actually brings on my back pain symptoms or makes me feel sick. All right, in that particular case, we would say, if you pushed your eyebrow, turned your head to one side, whichever side reduces the neural tension the most, push that particular eyebrow down into the table, that turns on the anterior chain, the flexors of the neck, the flexors of the core. I may ask them to push their foot down into my hand as well, and then they might say, ah, that takes my pain away. So it's just a stiffening strategy to engineer out or at least reduce the joint micro movements that we're starting to prove is causing pain in that particular example. Does it work for everybody? Of course not. But we have all of these different strategies to hone in on the precision of understanding their pain trigger.
I think we have more time for a couple more questions. What are your thoughts on heavy unilateral leg exercises? Do you believe they can cause instability on the SI joint?
Yeah, what a great question. Heavy unilateral leg exercises, I'm quite sure they can cause instability of the SI joint when done in excess. I think that, you know, the internet is a trendy place, and it's a very powerful place that creates a force for common or social behavior. And what I mean by that is a few years ago, there were a few trainers and therapists who were becoming concerned with two-legged squats, saying that this is causing back pain. People should do one-legged work, for example, a Bulgarian split squat or a loaded lunge or something like that. Well, people, again, another trend on the internet is that more is better. People should be trying to set personal bests and have a goal. Unfortunately, biology doesn't work that way for longevity. What happens is when people start doing unilateral leg work, Bulgarian split squats, a few is okay. You can add load, that's okay as well. But sooner or later, you're going to run up against the wall determined by biology that sets the biological limit. As you do a unilateral split squat, the one side of the pelvis mutates forward, the other side of the pelvis mutates backwards, or anterior or posterior, whatever your nomenclature is, and it stresses the SI joints. Over time, you will loosen those joints. So I've seen lots of patients now with true sacroiliac-triggered pain, and they trace it back to the heavy split squats that they were doing to try and save their back in the first place. So the trick to all of this is to respect the biological limits, and if you want a long-lasting athletic life, it's better to be slightly undertrained than it is to be overtrained, and not too much of any one thing, and you will be a happier 70-year-old.
Right. Now about back brace. What is your opinion on using a back brace for early stabilization in acute LVP patients?
Okay, well, that's a good question. My opinion on using a back brace for early stabilization of acute patients. I should be very clear. I rarely see an initial acute patient. I'm usually the person who sees patients who've already been to 10 different clinicians and they've failed them all or they've been made worse. So this would be quite rare for me. However, the science that we did about 20 years ago on different types of back braces and back belts, in fact, I was asked to write some of the policy for both Canadian governments and governments elsewhere, and corporations on this as well. I am not opposed at all to giving a brace to an acute person to help get them on their way. But what the science shows is you want to wean them off that as soon as they're able. Long-term use really can't be supported. Again, if you want the full scientific argument, pros and cons, how to prescribe them, etc., that's well detailed in a chapter in the low back disorders book. But I hope that gets the answer started on that one anyway. As with most of these answers, it's usually a it depends kinds of answer, and it's very patient specific. You'll find that I'm not dogmatic about any position. Yeah, I guess we'll just leave that answer there.
Good. And I guess we're running out of time. Just for the last question, I think this is what a lot of people are thinking. Do you still take on patients, and do you run any workshops at the university?
Well, yes, I do. I don't. When I see a patient, it's as a consultant. For me to see a patient, I need a clinician to refer that patient to me. I will do assessment. I will write a detailed report, and that report goes back to the clinician. It's not rare. In fact, quite often the referring clinician will accompany the patient to the consult, which is even better yet. So I very rarely see a person more than once, but we create a plan with the referring clinician to guide their recovery. Yeah, but I don't want too
else?
many of those patients. But yeah, do I do workshops at the university? Not at my university. I do them around the world, 7, 8, 9 of them a year. I just did one in Norway last week, and I do one in Costa Rica next week, for example. But they're all listed, at least the public ones are on our website under courses. That's at backfitpro.com, backfitpro.com under courses, and you'll see them there. Of course, I do private courses as well for teams and programs, but those are the ones that are accessible for the clinicians.
Great. I guess that's all the time we have for today. Again, for those who are registered for this webinar, you will receive an email with a link to the recorded version of the webinar. Thank you, Stuart, and thank you everyone for joining us today. And Dr. Stuart McGill.
Well, Marilyn, thank you so much for your professionalism, and to Stacy as well in putting this on today. Thank you so much.
Thank you, everybody.